Hey everyone, Dr. Evidentia here. We are jumping right into a seriously fascinating journey today, decoding the science of cholesterol. Now, before we get into the weeds, just a quick medical disclaimer. This explainer is built as a tool for evidence-based empowerment. It's education, not personal medical advice, so always chat with your own physician about your specific health needs. Today, we're unpacking the absolute latest research, untangling the complex web of lipid management, and honestly looking at some incredible medical frontiers that are fundamentally rewriting how we treat one of the world's biggest health threats. So let's get right into it. 86 million. I want you to just let that number sink in for a second. According to the latest data from the American Heart Association, that is the staggering number of adults in the U.S. alone walking around with elevated cholesterol. We are talking about more than a third of the adult population dealing with a condition that, wildly enough, usually has zero symptoms. But the consequences, they are anything but silent. Elevated LDL cholesterol is a primary driver behind 3.65 million fatalities linked to atherosclerotic cardiovascular disease. This is a massive, systemic issue, and it demands our absolute attention.
But what if I told you the future of treating this silent killer might not just be about taking daily pills? What if we could actually edit our cholesterol at the genetic level? We're talking about therapies that act like literal cellular mute buttons. It is an absolutely revolutionary time in cardiovascular medicine. If you're as pumped about the cutting edge of medical science as I am, take a quick second to like this explainer, subscribe to the channel, and drop a comment down below. It really helps us continue this mission of bringing reliable, evidence-based health education straight to you. All right, let's start our medical consultation.
Part 1. Under the microscope. To truly understand the cures, we first have to decode the biology and see how atherosclerosis actually happens.
We hear these terms all the time, but let's get our definitions straight. Low-density lipoprotein, or LDLC, gets a bad rap as the bad cholesterol. It helps to think of LDL particles as rogue delivery trucks. Their whole job is to transport endogenous cholesterol, the stuff naturally produced by your own body, through the bloodstream. But when you get way too many of these trucks on the road, they start dumping their cargo directly into the walls of your arteries. On the flip side, high-density lipoprotein, HDLC, is basically your cellular cleanup crew. HDL grabs that excess cholesterol from your peripheral tissues and hauls it back to the liver to be cleared out. The balance between those two is absolutely critical.
Because when that balance fails, clinical research maps out a very precise and very dangerous chain reaction. It all kicks off when elevated LDLC invades the inner lining of your blood vessels. This sets off a microscopic alarm, calling in immune cells that literally gorge themselves on the cholesterol. That causes intense oxidative stress and swelling right there in the vessel walls. The end result? Your arterial diameter shrinks, the plaque can rupture, and you're looking at catastrophic ischemic or thrombotic consequences, like a heart attack or a stroke.
We can actually break this whole disaster down into 5 accessible steps, but the absolutely crucial one is step 1, endothelial dysfunction. Whether or not LDL invades your artery walls depends heavily on your serum LDL levels, sure, but also on the health of the endothelium itself. The research points to this fascinating transcription factor called KLF2. You can think of KLF2 as a master traffic controller that promotes healthy blood flow to protect our vessels from inflammation. When KLF2 is doing its job well, it actually makes the endothelium much less susceptible to those invasive LDL particles.
Now here's a massive biological plot twist recently uncovered in the literature. For the longest time, we thought foam cells, those cholesterol gorge cells that build up in the plaques, were pretty much exclusively macrophages, which are a type of white blood cell. But newer studies show that vascular smooth muscle cells actually undergo a process called metaplasia. They physically transform to resemble macrophages. They start acting like this overzealous toxic cleanup crew that just makes the expanding plaque even worse. It just goes to show how insanely complex and dynamic arterial inflammation truly is.
So now that we understand the microscopic battlefield part 2, the gold standard, what exactly is our current playbook for treating this?
Well, decades of rigorous research point to one undeniable fact. Lifestyle modifications are always the foundational first step. Before we even talk about the pharmacy, we talk about the kitchen and the gym. The clinical guidelines specifically push for diets low in saturated fats. The DASH diet is a perfect example here, focusing on fruits, veggies, whole grains, and unsaturated fats like olive oil. You pair that with at least 40 minutes of moderate to vigorous exercise 3 to 4 times a week. For patients sitting at low to moderate risk, just doing that can drastically alter their cardiovascular trajectory.
But when lifestyle alone isn't cutting it, we turn to the clinical guidelines, and it's super interesting to see how global experts differ a bit on this. In the US, guidelines from the ACC and AHA heavily favor percentage-based LDL reductions and highly personalized risk assessments. They even use coronary artery calcium scoring to look at borderline patients and see if statins are truly necessary. Meanwhile, over in Europe, the ESC guidelines take a much more rigid, target-driven approach. They push for strict, absolute LDL-C targets. In fact, for very high-risk patients, the European experts want to see LDL levels driven down below a hard threshold of 55 milligrams per deciliter.
When we need to hit those ambitious targets, we pull from our established pharmacotherapy toolkit. Statins are still the undisputed gold standard here. They work by inhibiting an enzyme called HMG-CoA reductase. Put simply, they literally shut down your liver's internal cholesterol factory, which forces the liver to pull more of that bad LDL out of your blood. Now, if statins aren't quite enough, we add ezetimibe. That drug acts as a gatekeeper in the small intestine, blocking you from absorbing dietary cholesterol. And finally, we have bile acid sequestrants, which bind to bile in the gut, stopping it from being reabsorbed and forcing the liver to use up more cholesterol just to make new bile.
However, for some folks, those standard therapies are fighting a really tough uphill battle against genetics. Familial hypercholesterolemia, or FH, is a genetic mutation, usually in the LDL receptor gene, that causes lifelong, severely elevated LDL-C. Left untreated, it is a brutal genetic multiplier, shooting a person's cardiovascular risk up 10 to 20 times higher than the general population. For these patients, especially the ones with the homozygous form, we often need really intense early treatments. We're talking specialized drugs like mipomersen or lomitopatide, which work completely independently of the LDL receptor to essentially force cholesterol levels down.
Which perfectly sets the stage for Part 3, the frontier. What on earth do we do when statins just aren't enough?
Enter the PCSK9 inhibitors. The data comparing statins alone to adding in these monoclonal antibodies like alirocumab or evolocumab is dramatic. See, PCSK9 is a protein that normally degrades the LDL receptors on your liver. By inhibiting that protein, these injectable drugs stop the degradation, which leaves a ton more receptors available to clear LDL out of your blood. When you use them synergistically with statins, patients see roughly a 60% additional drop in their LDL-C. It's a massive, massive leap forward in secondary prevention.
And the innovation definitely doesn't stop there. We're seeing a whole wave of emerging therapies transitioning right out of clinical trials and into practice. Now, to be clear, these are different from our established mainstays. We've got evinacumab, which is a monoclonal antibody inhibiting a protein called ANGPTL3, showing a solid 47% reduction in LDL-C. Then there is bempedoic acid. That one targets cholesterol synthesis upstream of where statins work, which makes it a fantastic alternative for patients who get statin-induced muscle pain. But there's one drug making waves that represents a true paradigm shift in pharmacology. I really want to spotlight inclisiran. This is not just another chemical blocker. It is a small interfering RNA treatment. It literally works at the genetic level to halt the production of the PCSK9 protein before it is even fully formed. Again, think of it as a cellular mute button for that specific gene. But what's truly incredible here is the convenience for the patient. After the initial loading doses, it requires a quick injection just under the skin only once every 6 months, all while still giving patients a durable 51% reduction in LDL-C. Twice a year for that kind of result is just phenomenal. We have covered a tremendous amount of ground today. Let's synthesize all of this into clear takeaways for Part 4, the prescription, and map out your informed health journey. Here is the bottom line for you to take away from this explainer. First off, atherosclerosis is not just a simple plumbing problem of clogged pipes. It is a chronic inflammatory disease driven by long-term LDL exposure. Second, I don't care how advanced our drugs get, a healthy diet and regular exercise remain your foundational defense. Third, statins are still the evidence-based gold standard for safely lowering risk in the general population. And finally, for those who need more aggressive help, RNA and genetic therapies are opening some breathtaking new frontiers. Just remember, you always need to discuss your specific cardiovascular risk profile and absolute LDL targets with your personal healthcare team. I want to leave you with this pretty powerful thought. As we refine our ability to literally edit our cholesterol at the genetic level with these RNA therapies, are we actually looking at the beginning of the end for atherosclerotic heart disease? The science is moving incredibly fast, and honestly, the future is looking incredibly bright. My mission as Dr. Evidentia is to help you navigate this fast-paced world so you can make empowered, informed health decisions through reliable evidence.
Thank you so much for joining me today. Keep asking questions, keep looking at the evidence, and I will see you in the next explainer.